Hi, I'm Paige Pelletier, and this is Cody Cox, and we're here to talk to you about our patient with chronic ankle instability. So a little bit about our patient. He's a high school senior marching band drum major with left lateral ankle instability. A little background on him. His name is Cody. He's 18 years old, and he's been in the marching band for 8 years now. He's his leading high school drum major, and he has a scholarship on the line with The Ohio State University. He came into our clinic on March 20th, 2017, complaining that he rolled his foot in during rehearsal on the blacktop when he accidentally stepped on a drain gate. He attempted to finish his rehearsal, but was unable to due to his pain, swelling, and instability he felt when walking. Some signs we observed during our initial eval was swelling, bruising. He was tender to palpate. His ankle felt very unstable, and he had a limited range of motion. We had a positive anterior jaw test and talar tilt test while inverted, and his range of motion and manual muscle tests were all very limited due to his pain and swelling. The diagnosis we came up with was a grade 3 lateral ankle sprain, and we found it as a result of his chronic ankle instability. So a little injury background on what a grade 3 lateral ankle sprain is. This is when you have a complete tear of the ATFL, PTFL, and CFL ligaments. Each day it's estimated that 23,000 of these occur, and they account for 85% of all ankle injuries, with 85% being lateral ankle sprains. The mechanism of injury for a lateral ankle sprain is inversion, as demonstrated here with your foot rolling inwards, so the ligaments on the outside of your ankle are damaged. The structures involved. So we have our PTFL, which is our posterior talofibular ligament going from the talus to the fibula, anterior talofibular ligament going from the talus to the fibula, and calcaneofibular ligament vertically oblique from our calcaneus to our fibula. We also have to consider the musculature on the lateral region of the ankle. Two main muscles we want to look at are peroneus brevis and longus. Why does this instability recur in these patients? There's two categories: mechanical, which occurs from pathological laxity, changes in your synovial cavity, and degenerative conditions that affect the hindfoot and hindfoot stiffness. Functional is impairments to proprioception and neuromuscular control. So your brain and ankle aren't communicating well about where it is in space and the pressures involved with it. So now we're going to talk about the conservative management of a grade 3 lateral ankle sprain. This is management involving no surgery, just rehab. Range of motion. So we're going to try and draw each letter of the alphabet just to work all motions of the ankle. Phase 1, this is from time of injury to about 2 weeks out. Our main goals are going to be controlling his edema, pain, and spasming. We want to protect his ligament from excessive stress, so we definitely have him on crutches and then progress to a walking boot, partial weight bearing. Some examples of a SMART goal we would have: reduce patient pain from 8 out of 10 to 2 out of 10 by March 31st, 2017. During this phase, we're not going to do any exercises. We're going to be focusing on our modalities. So RICE is just rest, ice, compression, elevation. We might do some manual therapy, massaging to get the edema out of his ankle. So that's it for phase 1. For phase 2, this is going to be about weeks 3 to 5. Our goals are going to be to increase range of motion, maintain his endurance, and at the end of the phase, make some early strength gains with isometrics. An example of a SMART goal we have are increase ankle dorsiflexion from 0 degrees to 15 by April 3rd, 2017. So for this treatment, we're going to do early strengthening, as I mentioned, non-weight bearing, isometrics. We can even get aquatics in there, and then progress to manual resistance as tolerated. For phase 3, this will be weeks 6 to 8. Our goals are that he should have full range of motion by now, but we'll continue to work on that. Increase his strength, endurance, and proprioception during this time, and maintain his conditioning levels as always throughout the rehab. An example of a SMART goal we have is to that increases lower extremity endurance as demonstrated by performing squats on the total gym for 4 minutes straight by May 9th, 2017. For the treatment here, we're going to focus on early functional exercises including balance, and if we need joint moves, they're going to be grades 3 and 4. For the final phase of the healing process, we have weeks 8 to 12, hopefully. Our goals are going to be that he is ready to return to play and perform functional and sport-specific activities. A SMART goal for him would be being able to perform his drum major run for 40 yards in under 10 seconds, because this is something he typically do in his routines, and he needs to be back to that speed. For our treatment, we're going to focus on plyometrics of the lower extremity, and then he'll be ready to go back to his pre-injury status.
We're going to cover the surgical intervention for lateral ankle instability. Currently, right now, the golden standard for fixing a lateral ankle instability is the Broadstrom-Good technique. This involves drilling a hole into the distal tibia and running fiber wire through the frayed or dismantled ligaments of the lateral ankle. Then you anchor down and connect it to another hole bored in the distal tibia as well to connect it all together. There currently is no scientific research to support which one is preferred between open or arthroscopic procedures, although there is a case study in the making right now that will be finished in 3 years to give us that research. Differences between surgical and conservative are the time frame for rehabilitation. The surgical will take longer. There are more risk factors because it is surgery. You do have a new wound, but it could lead to being fixed in the long run more specifically. Phase 1 is mostly going to be focused on decreased swelling, edema, pain, and different things of that nature. So, one thing that we're going to focus on is rices. It's going to be huge in the surgical treatment especially, and it's going to last between 0 and 2 weeks. They're going to be non-weight bearing, and one of the goals is strictly going to be to reduce edema and get the ecchymosis flowing out of the lateral ankle. One thing that we're going to do to prevent deconditioning is we're going to do quad sets and hamstring sets. That way, we can still have the muscles working and active while the lower ankle is being fixed. In phase 2, we're mostly going to be worried about range of motion and flexibility. So, shout out to you, Eugenio. Ankle pumps. You know it. You knew it was coming every time. So we're going to be also doing the BAPS board and towel scrunches, different things like that, trying to get the range of motion, the flexibility, and the joint moving all together just to progress to phase 3. Phase 3 is going to consist of weeks 6 through 10. So one thing we're going to be working on is strength and proprioception and things of that nature. So we're going to be doing monster walks, lunges with curtsy lunges, and then we're also going to be working on squats on a Dynadisc. That'll really help the proprioception as well. And then phase 4 is more aggressive. We're going to be more into sport specific. We do have a drum major that wants to get the big scholarship. So one of our main goals is that he's going to have to complete that 40-yard drum major dash, and it's going to be coming up, and so he's got to be able to do it. In order to do it, we're going to be using the agility ladder, we're going to do box jumps with bounds, and we're going to be doing suicides to help get the endurance up.
That's all we have.
This is a BAPS board. It's mostly going to be used for range of motion during the early parts of exercise. It's important, though, to keep focus on not moving your knee and only really moving at the ankle and touching all of the outer parts of the board to the ground.
So this exercise is great for the early stages of rehab. We can control how much body weight they're walking at. I'm walking at 50% right now, so we can increase to full weight bearing. They can also walk backwards, do lunges, squats, all partial weight. On our total gym machine, we can perform calf raises, squats, and eventually progress to one-legged squats, all while controlling the amount of weight bearing.
And then we're going to start with marching, and then as we progress, we're going to do cone marches. Getting higher and higher as you move. From lunges, we're going to progress to split lunges with a jump.
For sport-specific and proprioceptive activity, we have him standing on an Arex while twirling a baton, which would mimic what he does as a drum major on the field. Another sport-specific activity we can do are lateral dynamic step-ups while twirling the baton, which would mimic what he does as a drum major on the field. To mimic quick acceleration and deceleration as well as lateral cutting movements, we'll have the patient do suicides